Welcome. The mission of Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We welcome you to our 2018 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and today we are pleased to be joined by Dr. Gary Stephen, who will talk to us about the over-reliance of steroids in severe asthma. Dr. Stephen is an allergist immunologist in independent practice in Milwaukee, Wisconsin, an assistant clinical professor of medicine at the Medical College of Wisconsin, and an adjunct clinical professor in the College of Nursing at the University of Wisconsin-Milwaukee. If you can advance one slide, please, Dr. Stephen. He earned his PhD in immunology at the University of Wisconsin-Milwaukee and completed medical school and internal medicine residency and his allergy fellowship at Medical College of Wisconsin. He has been in private practice since 1996 and has supervised over 150 clinical trials since 1994. He is the executive director of Fight Asthma Milwaukee Allies, a 501c3 nonprofit dedicated to improving asthma care in Milwaukee County, and serves on several committees, as well as the Board of Regents of the American College of Allergy, Asthma, and Immunology. Most recently, he was elected by his peers into the Best Doctors in America for 2017-2018. Dr. Stephen, we're so glad you're here with us today, and we look forward to hearing the information that you have to share with us.
Well, thanks so much, Sally. I appreciate the introduction. This is a topic that is kind of near and dear to my heart. Severe asthma causes a great deal of the pain and suffering throughout the world. And it is very difficult to make sure that everybody gets the appropriate treatment that they need. One of the easiest ways of treating severe asthma is to use oral steroids. It is what all of us with severe asthma have had at some point in our lives when we have an exacerbation of asthma. It is the best medication that we have to bring down the inflammation of an asthma exacerbation as rapidly as possible to relieve symptoms. However, it is something that is to be used only for these acute exacerbations with severe symptoms for short periods of time to get the asthma back under control. But we want to try whenever possible to not use oral steroids for long periods of time, and we'll get into some of the reasons why that is throughout the next 45 minutes. The difficulty with it is that it's inexpensive and very easy to use. So it's very easy to fall into the trap of relying too much on the oral steroids, where we're focused more on the immediate benefits and we don't pay as much attention to the long-term risks. So that's the overview of what we're going to go into today. So we're going to discuss what the oral steroids are, a little bit more detail about why we use them. Get into a deeper understanding of the difficulties with the long-term use of oral steroids. And we'll touch on a few other treatment options that are available to control severe asthma short of using the inhaled, using the oral steroids, so that the patients have a better understanding of what all of their options are, and so that they can be asking questions. And if there's something that just doesn't seem right, and you think that you're using too much of the oral steroids, you can ask the right questions, get into a better discussion with your prescriber, and to explore other options that might work as well or even better with fewer risks. So the oral steroids are called corticosteroids. They're produced by the adrenal glands in the body. These are Not the anabolic steroids that people commonly talk about for muscle building. So no, they don't. They don't help you build muscles. The corticosteroids are anti-inflammatory steroids. So they work anywhere in the body where there is inflammation, which is kind of cool, and it's one of the challenges with using the oral steroids. Patients like it because everything gets better. Anything that's inflamed in the body gets better when they're on the oral steroids. But as far as it pertains to asthma, they're used to reduce the inflammation in the airways. Inhaled steroids, which any persistent asthmatic should be on, is the preferred anti-inflammatory medication for the asthmatic airway inflammation, because we get the benefits of the oral steroids in the lungs where we need it. But since we're inhaling tiny doses into the lungs right where it needs to be, we don't have to expose the rest of the body to the oral steroids, which is what happens to the steroids, which is what happens when you take oral steroids. When you take steroids such as prednisone or dexamethasone by mouth, it is absorbed from the stomach. You build up a blood level of the steroid so that all of the organ systems in the body get exposed to the steroid, not just the lungs. And in asthma, since we're dealing with treating the inflammation specifically in the lungs, it works out great to use the inhaled steroids and put the steroids right where we need it without exposing the rest of the body. And in so doing, we avoid all of the complications and side effects that we get when the rest of the body's organ systems get exposed to the steroids. And so all the asthmatics with persistent airway inflammation should be treated with the inhaled steroids. And then if that is not enough, if there is an exacerbation, if they get a viral infection or have a huge allergen exposure and the inflammation becomes more than what the inhaled steroids can control, then we can use a burst of oral steroids for a few to several days to bring that inflammation back under control to where the inhaled steroids can be working again. The reason for using the oral steroids is because for these exacerbations is that the inhaled steroids don't penetrate deeply enough into the lungs, and so we need to get the steroid to the lungs through the bloodstream. One misconception is that the steroids are something that's foreign to the body. It's actually not. Like we mentioned a couple slides ago, the adrenal glands make the steroids, and they make about 5 milligrams of prednisone every day. It is when we take doses above that, and for those of you who have had asthma exacerbations, you've taken 20 or 30 or 40 milligrams a day for a few days, and that increased dosage brings that inflammation under better control. And this is an illustration of why we need to use oral steroids with severe asthma. In the upper left corner is a picture of the lungs. What these pictures were is they had people inhaling radioactive helium, a tracer that will show up on a radiation camera. And so and you do this for a few breaths. So in the upper left corner, that is normal lungs, where you see the air is going into and getting distributed throughout the entire lungs. If you move over to the upper right corner, this is an example of mild asthma, where a patient with asthma was having an exacerbation. There is some bronchospasm, a closing of the airways. The air can't get, and then of course the radioactive helium can't get into all parts of the lungs. And so all of those areas that you see that are black are areas of the lungs that are not getting air. And if they're not getting air, then they're not getting the inhaled steroid that you're trying to inhale. And then as asthma gets more severe, and the the lower left corner, and then really severe in the lower right corner. Large sections of the lungs become blocked off, either from that constriction of the airways, that bronchospasm of an asthma exacerbation. There's also mucus plugging. People who have had significant asthma exacerbations often cough up some mucus afterwards. There is an overproduction of mucus during an asthma exacerbation, and that is often thick and blocks the airways. And so when there's substantial mucus production, as you can see in that lower right diagram, you can block off substantial areas of the lungs, and so those parts of the lungs are not getting the inhaled steroid that you're trying to breathe in from your inhalers. And so in these more advanced stages of asthma, we need to use the oral steroids, bring the steroids to the lungs through the bloodstream so that all of the lungs can get treated, not just the part that is getting treated with the inhaled steroids. So just in summary, the oral steroids and the inhaled steroids are the first line treatment for persistent asthma. In severe asthma, when we are not getting air into all areas of the lungs, the oral steroids give us an opportunity to get much better control, much more rapidly. So like any other medication, the oral steroids work best when taken as they are prescribed, and they don't work as well if you don't stick with the treatment plan. We typically start off with higher doses of steroids, and because steroids are produced by the adrenal glands in the body, and the adrenal glands regulate the amount of steroid present in the body, when we take a bunch of steroid orally, the adrenal glands sense that, and they stop the production of steroids, because they can see that, well, there's plenty of steroid in the bloodstream. We don't need to contribute to that. And that is why whenever a doctor gives you a course of prednisone for longer than about 5 or 6 days, you take decreasing amounts every few days until you gradually taper off. And that is so that the adrenal glands can see that steroid level is going down, and they kick in and start making their own again. And that's why it's important to use the entire prescription as prescribed, starting off with the higher dose to get the inflammation under control, and then slowly taper off so that the adrenal glands can wake up and make their own steroid again. And it doesn't work as well if you don't take it as prescribed. And sometimes people just forget. It's hard to remember to take medication, especially if you're not used to taking pills on a regular basis. And then part of the reason for this webinar today is to help you understand the reason for taking the entire course, and the reason why you want to taper off the steroid rather than just stop it abruptly, because that's a hard thing to do. After 2-3 days of high dose steroids, you're feeling fine and you think you don't need to take the rest of it. But in order to keep the adrenal glands functioning regularly and normally, you need to take the entire prescription as prescribed and slowly taper off. People do get concerned about the side effects of the medication. We're going to talk about that a little bit. And sometimes it's hard to keep in mind that we're using these medications to prevent more severe exacerbations or re-exacerbations. And that's the most important thing that needs to be kept in mind, is that the dose of oral steroids and even an inhaled steroids that is prescribed is intended to get the lungs as close back to normal as possible, and to keep it that way so that we're not continually re-exacerbating and then trying to get back on track. So what we try to do for the most part with the the controller regimens, using inhaled steroids on a regular basis to keep asthma under good control, is to make sure that control is good enough so that we don't need more than one burst of oral steroids per year, and we try to reduce the daily use of oral steroids in severe asthma as much as possible. From a healthcare provider standpoint, we're looking at the same goals. One thing that we emphasize when in educating primary care physicians is that if a patient with asthma is poorly controlled and using 2 or more bursts of oral steroids per year because of repeat exacerbations, they really should be thinking about referring the patient to an asthma specialist to see if there are better ways to keep the asthma under better control over the long term. And for specialists, success in oral steroid use involves engaging the patient with shared decision making to make sure that patients understand all of their options, all of the different forms of treatment, and we can guide the patient to choose a treatment plan that works the best for them, that is consistent with their own beliefs and preferences. So we already touched on some of this stuff, especially the first point. Patients don't mind taking in oral steroids because they like the way they feel on them, and it's a lot easier to notice that you feel great than it is to keep in mind the long-term complications of it. It's easy to get the prescriptions covered for oral steroids because they're cheap, and insurance companies want people to stay out of the ER in the hospital, and so that they don't care, how much oral steroid we're using because we're saving them money. But the difficulty, the thing that makes it harder to track is that the real significant adverse effects of oral steroids are based on the total lifetime cumulative dose, not how much you're taking today or last week or next month, but the number of bursts of steroids that you take over your lifetime and the total amount of steroid you take over your lifetime is what feeds into the side effects. So it's always important to share with your healthcare provider how much oral steroid that you're getting, even if it's not given by them. Somebody, your primary care doctor or your asthma specialist, needs to have a good idea overall about how much oral steroid a patient is receiving. Now, we're talking about a small subset of asthmatics. Only about 5 to 10% of asthmatics have severe and persistently uncontrolled asthma. But this small amount of asthmatics are responsible for a lot of the healthcare costs, because they're the ones that are using the multiple inhalers, going through them rapidly, getting exacerbations, going to the ER, getting hospitalized. But part of these costs that we want to keep in mind is that there is also a cost to treating the side effects of the oral steroids that we're going to get into in a little bit. So the questions that we all need to address, both from a prescriber's standpoint and also from a patient standpoint, are we using oral steroid bursts more than we should? And should we be stepping up our day-to-day controller regimen to decrease that? And do healthcare providers really have a good handle on how well their patients' asthma is controlled, and are they really getting a good feeling for how much the um, how often they're having exacerbations that are requiring ER visits, urgent care visits, or even going to the convenient care clinics that do not report back to the patient's asthma specialist that they were seen or what was prescribed. So one of the goals of this webinar is to make sure that the patients are empowered to act on this, and they are activated to seek alternative treatment options if they think that they're using oral steroids too much, which is a different kind of conversation. The conversations that we typically have are, how these are the problems I'm having, how do we make this better? But we want to switch that around to say that I don't think that I'm as controlled as I should be. What else can we be doing about this? And we pretty much talked about those last 2 points, so I think we'll move on. So the healthcare providers, not only do they need to get that information from the patients and where all they are seeking care for uncontrolled asthma, but they also need to have an idea of what to do when confronted with a patient who is using a lot of oral steroids. So you need to raise a concern with the patient that, yeah, I know you feel good when I give you a burst of oral steroids, but this is a problem. Here's some of the options that we can utilize to decrease that reliance, and go over how to access those other treatment options. And that is a very difficult thing to do in our current healthcare ecosystem. So this kind of summarizes all of what we've been talking about. So that the issue is that we're able to control the asthma with the oral steroids, but that does lead to a lot of side effects, jeopardizing the patient's long-term health. And with our current system of various points of care that people have available to them, it's sometimes difficult to connect all the dots to really understand a patient's overall asthma control. And the challenges, as we mentioned, is that the oral steroids are very effective, and they're easy to take, and very affordable, and they give people the quick relief that they want. They don't want to get out of this exacerbation over several days to a week. They want to be better later on today. All right, there's some, excuse me. So we've talked about the need for oral steroids and the need to reduce them, and the main reason is to avoid the side effects, which we'll get into now. Side effects don't happen to all people, which is another misconception. People get a prescription, look at that long laundry list of side effects, and think that that's all going to happen to them. No, those are just adverse effects that have happened to people who were in the clinical trials of that medication when it was being developed to bring to market, and that not everybody gets all or even some of those side effects. But the higher the dose and the greater the lifetime cumulative dose, the more likely the people are to get side effects, and the more severe those side effects are going to be. So we always want to try to reduce the total amount of steroid necessary to control the severe asthma. So one of the difficulties is that the alternative, we talked about the steroids are relatively inexpensive, and that means that all of the alternatives to that are much more expensive. And so the insurance companies do put up barriers to utilizing some of the more expensive treatment options. And so we need to have a full, totally balanced approach to that, looking at the pluses and minuses of the consequences of the treatments themselves, together with the costs of those various treatment options to come up with the best way to control a patient's asthma at a reasonable cost. But we also want to factor into some of these long-term costs, like the cost of treating the side effects of the steroids. And we want to make sure patients are educated about what these side effects are so that they can recognize them and intervene early. So we'll get into that a little bit. We're talking around it a little bit. So here's a few slides that go into the specifics of it. Now, the corticosteroids are hormones. I already mentioned the way that the adrenal glands regulate the amount of steroid in our body. And when we have an excessive amount of it, when we take oral steroids, we're taking more steroid than what our body would otherwise produce by itself. And so these are some of the adverse effects that you get when you're taking more than that 5 milligrams of prednisone every day. You can increase the growth of body hair. The fat distribution around the body changes. When you have high levels of steroid, you tend to put more fat around the middle or around the face, or in the upper back. You get what's called the buffalo hump with chronic steroid use, and it can also adversely affect blood pressure. Some of these other hormone effects can affect the appetite, which is very difficult to deal with. It's very common for people to gain some weight just from fluid retention, so swelling of the hands and feet while they're on steroids, and that fluid gets excreted once you're off of those steroids. But if the oral steroids increase the appetite and you eat like a horse for a week or two while you're on the steroids, you will put that weight on, and that weight is a lot harder to get off than some water weight from fluid retention. In a minority of patients, fortunately, this doesn't happen much, but some patients do get some emotional disturbances. Because some people feel great, especially those with arthritis. Their joints feel better, and it just uplifts their entire mood. And you can see, all the way on the other expression, on the other end of the spectrum, some patients get depressed when they're on oral steroids. But those effects are only while taking the steroid. That does go away once the steroids are finished. Some of the more serious effects that happen with prolonged use and that lead to more costs that we were talking about, the costs of treating the adverse effects, are things like stomach ulcers, glaucoma, increased pressure within the eye, cataracts, osteoporosis, and people who have been on high-dose inhaled steroids. It's just not working. They need to be on oral steroids, and for those that we can't use other alternatives on, people are on oral steroids for long periods of time, we do need to be screening for all of these potential complications so that we can reevaluate the treatment and intervene early if necessary. One of the more significant and unfortunately more rare long-term implications is called osteonecrosis, where the parts of the bone die. It's very common to occur in the hip, and what happens is the fat builds up inside the bones, which squeezes off the blood vessels, and bones are living tissue. There is a blood supply in bones. There are cells that live in the bones, and with this fat, when this fat builds up and chokes off the blood supply, these bone cells die, and we do see people that have to have hip replacements because the hip joint has died from long-term steroid exposure. Steroids also decrease the vigor of the immune system, and we do see an increase in serious infections like pneumonia. And we do see a reduction in the growth rate in children on oral steroids. And that is a concern. It is something that we want to be monitoring. But again, it is not a reason to not use the oral steroids when you have to. You just have to make sure that if you use it, you have to. Because kids don't grow well if their lungs aren't in good shape either. So with the inhaled steroids, there's not much of an effect of growth, maybe about a half an inch in kids that are on inhaled steroids, throughout their entire childhood and adolescence. But we always have to keep in mind that the adverse effects of not treating the uncontrolled asthma is a lot worse than the side effects of the inhaled steroids. So then just to sum that all up, an empowered patient is aware of the potential side effects of long-term use of oral steroids. We need to have the discussion about side effects when, especially when contemplating long-term, chronic use of oral steroids. A patient needs to know about these and watch for these side effects, and make sure you have that discussion to reevaluate the treatment options if any of these adverse effects are getting started. So we talked about that oral steroids are inexpensive and that severe side effects drive the need to look for other options, and there are several. In the last 15 years, especially in the last 2 or 3 years, we've had the development of biologics, injectable medications that go after a specific inflammatory component of asthma without all of the other side effects that you get with steroids. One of these is an injectable medication, an antibody that removes allergic antibody in the system, making people less allergic. And it works best in people whose allergies are a major driving force in their asthma severity. And omalizumab is the only biologic on the market in this class. It does need to be administered in a healthcare setting. It's anywhere from 1 to 3 injections every 2 or 4 weeks. And there have been some injection reactions reported with that. And so the injections need to be given in a healthcare setting with monitoring for these reactions. The eosinophil is a type of white blood cell that is involved in asthmatic inflammation. And we have several biologics on the market now that reduce these eosinophils and thereby reduce the asthmatic inflammation. And all of the studies that were done to bring these drugs to market looked at, well, what's the downside of getting rid of all of these eosinophils? And the answer to that was there really isn't anything. So there may be an issue in people who live in areas that have a lot of parasitic infections, like South America. But in North America, there's no downside to removing these eosinophils, and they can be very, very effective in certain types of asthma. 2 of them remove the growth factor for the eosinophils. One of those that's most recently on the market results in the destruction of these blood cells. And these are also administered in a healthcare setting. These are just a single injection, just once a month or less. And so it's a very easy treatment regimen. There are other ways of suppressing the immune system, such as cyclosporin and azathioprine, that are not steroids, so their adverse effects aren't as wide-ranging as with the oral steroids, but they can be associated with the damage to the liver or kidneys. And people who are given these immunosuppressants do have to have their liver and kidney function monitored But for those and they stop the treatment if there's any signs of trouble. But for those that don't get any adverse effects on the liver or kidneys, there's usually fewer total side effects than with these immunosuppressants than with the oral steroids. Bronchial thermoplasty is a technique that actually cuts through some of the thickened muscle in the airways to prevent the airways from clamping down. And it is a procedure done by a pulmonologist in 3 separate occasions, where you use a hot wire to actually cut through the muscle fibers, which sounds kind of scary on the surface, but this has been around for quite a while, and we have safety data on people that have had this done more than 10 years ago, and I find that it's very effective at reducing asthma exacerbations and is really not associated with any significant adverse effects on the lungs. So the opportunities that we have to curb the over-reliance on steroids and minimize the adverse effects of the oral steroids are to share this kind of information. Make sure that asthma control is being assessed by healthcare providers and the asthma specialists using a variety of methods that can objectively assess how well asthma is controlled. The Allergy and Asthma Network, together with the American College of Allergy, Asthma, and Immunology, put together a shared decision-making tool that helps patients understand the options that we have for treating severe asthma, and is a good springboard for that discussion with their asthma specialist, and helps to get all of this information into an educational format for the patient. And of course, with any aspect of healthcare, patients always need to be asking questions about all of the various treatment options available to them. So the upshot that what you want to be looking for, if you think that you're using being prescribed steroids too much, we want to make sure that we're not using more than 1 burst of oral steroid per year. We want to make sure that for those very severe asthmatics, we're keeping the chronic daily use of oral steroids to an absolute minimum. We want to be aware of the side effect profile, both of the oral steroids and some of the alternatives for use, looking at the advantages and the benefits and the risks and the costs of all of these different treatment options, and keeping in mind the cost of the complications of overuse of oral steroids. And that pretty much sums it up. Do we have any questions?
We do. The first 2 are a little bit more of just like housekeeping. Someone asked me to review again where you get your certificate of attendance. If you look on your control panel for your GoToWebinar, there's a section that says handouts. You can download your certificate right from there, but I suggest you do that now rather than waiting for the end of the program, because at the end of the program, we close it and that's not available anymore. If you have trouble downloading your certificate, you will get a follow-up email from the network, and my email address is in there. Email me and let me know, and I'll send you one. For another question was, would we send you a copy of the presentation? We don't share the slides. And the reason for that is that, first of all, it's the intellectual property of our presenter, but also these webinars will be available in our learning center, our online learning center that we're going to be opening up in June. And then it will be there will be a charge for continuing education credits if you want those. So for that reason, we aren't sharing the slides themselves, but you can listen again for free. It's on YouTube. There'll be a link on our website, usually within about 48 hours, to listen to it again. And that link will be in your follow-up email as well. So, Dr. Stephen, I think you approached this after the person probably wrote the question. The question was, can the doctor give examples of the side effects of over-reliance of OCS? So I guess what I'd ask you to do is just go over again the most dramatic side effects that we should be concerned with.
Yeah, sorry about that. I thought of that as I was speaking. I was talking about the side effects for quite a while before I actually got to the point. But yeah, the main side effects of the short term are the fluid retention, increased appetite, mood disturbances. But the longer term, the chronic steroid exposure results in stomach ulcers, cataracts, glaucoma, and osteoporosis, which sometimes gets as severe as parts of the bone dying off.
Okay, we have a parent who's written in. She says, my son, who's been diagnosed with asthma since age 9 months and has used different steroid nebulizer inhalers since then, he's now 10 years old. For the last 2 years, he's been on 1 puff of Symbicort 80 once a day with his asthma well controlled. But in the last few months, he's had a breakout wheezing and is back on 2 puffs twice a day of Symbicort 80. He's also gained significant weight this past year and is on the shorter side for his height. Have inhaled steroids significantly impacted his height and weight? And how long is too long on inhaled steroids? We're gearing towards starting oral immunotherapy soon for severe food allergies, so we need his lungs to be healthy before and during treatment.
Those are some excellent points. The best way of approaching that is to make sure that the asthma specialist is performing measures of airway inflammation. One of the ones that's most commonly used is exhaled nitric oxide, which correlates very well with airway inflammation, and we want to make sure that we're using a dose of inhaled steroids that brings that nitric oxide level down into the normal range. And unfortunately, if we're just limiting ourselves to using inhaled steroids, if we are measuring that airway inflammation, making sure that we're on the lowest possible dose of inhaled steroids that maintains that control of inflammation, then we kind of just accept whatever that does with the growth, knowing that if we're not using that much inhaled steroid, then the increased inflammation in the lungs is going to put the brakes on the growth even worse than what the inhaled steroids do. And if that continues to be a concern, if we know that we're on the minimum effective dose of inhaled steroid, we're still concerned on how it's adversely affecting growth, then it's time to look into one of these other biologics or maybe an allergen immunotherapy if there are significant environmental allergies to decrease the amount of inflammation without the need for more steroids.
Okay, thank you so much. Our next question is, can inhaled steroids replace 10 milligram or 16 milligram pills if you've been on pills long term? Would inhaled be enough to keep from going into adrenal withdrawal shock?
It depends on what you mean by long term. It is a theoretic concern. I've only seen it once in my career where somebody was on on oral steroids at a sufficient dose for a sufficient period of time that when these other medications, the biologics came along, we got better control of the asthma and were able to get her off the inhaled steroids. The adrenal glands never woke up, and she started to go, and we were watching for signs of an adrenal crisis. Her serum electrolytes were starting to go out of whack, and then we put her back on that 5 milligrams of prednisone every day. because her adrenal glands were not going to wake up. So that is, everybody is different. There are no guidelines for that. You can't say, okay, this much steroid for this many years will shut down the adrenal glands permanently. All you can do is slowly taper off the oral steroids and watch for signs of adrenal crisis.
Wow, that's great information. Next question is, are side effects of inhaled steroids similar to OCS, the increase in weight, mood changes, and decreased growth?
Yes, but usually always much less than oral steroids. You typically don't see much of that. The kids will exhibit signs of that. I do have one patient whose parents were quite sure that her face was puffing up after a few months on an inhaled steroid, and that went back to normal after we discontinued that. And then her nitric oxide level started to go up again. So we're trying a different inhaled steroid to see if she tolerates that better. But these adverse effects can and do occur with inhaled steroids, but way less than they do with oral steroids.
Our next one is pretty much a statement, and it's a great one. She says, excellent overview, thank you. Shared decision-making and tools to do so are wonderful and necessary. As a primary care representative, it's hard to fit it all within a 15 to 20-minute visit. That's why our primary care organization has an asthma educator full-time. Well, I would like to clap when I hear that. That's wonderful.
That is the way it should be done, absolutely.
Okay, the next question is, what is the difference between burst and tapering advantages?
The burst is often sufficient, and you'll hear varying definitions of that. The most common is 7 days. A lot of prescribers are nervous about that. Pretty much anybody will give the same dose for 3 to 5 days and then stop. And that has to do with the adrenal glands waking up. So, and it will take typically 5 to 7 days for the adrenal glands to shut down their own steroid production. And so once you have been giving the steroids for 6-7 days, you do need to taper that off to allow the adrenal glands time to wake up and start producing steroid on their own.
Okay, great. I have a school nurse here who's asking if there's a parent information flyer or page that you would recommend. She has lots of opportunities to share information.
I think the Allergy and Asthma Network can answer that better. The network has all kinds of resources for that. I don't have anything off the top of my head.
Well, I think the best resource I would recommend to you is our Understanding Asthma Guide. It's basically an Asthma 101 that is written at a 6th grade reading level so that parents and patients of all levels can understand it. And we certainly have lots of copies of it in the office, but we are going to be coming out with an expanded version soon that will be specifically targeting some of these questions about severe asthma. So if you want to head to our website, you can certainly find information there. If you want to email me, I'll be happy to help you specifically. Here's someone that says, I was diagnosed with asthma years ago, but have not used any meds for a long time. Does asthma ever go away? Is there a possibility I will need OCS in the future?
OCS, probably not. We never speak of asthma as being cured. It can be quiescent. It might never come back. But people who have had asthma earlier in life are always at risk of it coming back. If it does go away for several years or decades, it does not come back with a vengeance. And as long as you manage other risk factors, obesity is associated with asthma severity, exposure to allergens, exposure to irritants, other medical problems that could arise later in life. All of these can affect the severity of asthma if and when it recurs later in life. But in general, people who do see have this period of time during their life where they are asymptomatic, asthma is not going to come back that severe that you would be requiring oral steroids.
Okay, so a next question is, Dr. Stephen, do you know when to step down therapy for your patients on ICS?
There's some controversy on that. So I'm assuming that question is based at is aimed at the guidelines that recommend stepping down off of long-acting bronchodilators after 3 months, and the crux of that is the patient situation. And if I have a new patient that I'm putting on a long-acting bronchodilator, yeah, I probably will step them down in about 3 months, because I don't know where, they're coming into me acute, with significant symptoms, but I don't know what their baseline really is. If this is somebody that I have seen from early on, especially if a younger person who comes in with allergic rhinitis and while they're a patient in my practice, they develop asthma, and I see how the asthma is going over time. And I try various interventions and assess the response. And if I wind up on medium or high dose inhaled steroids, it's for a very good reason. And the underlying problem is not going to go away right away. And then, so if I know that somebody is well controlled under the appropriate goals, which is the maximal control, maximal lung function, with the least amount of medication necessary to get us there, that's not going to change in a short period of time. And if I have somebody who's been stable and has not used any albuterol at all for a couple, 3 years, we'll start stepping down.
Okay. Our next question, I think, is from a school nurse. She says, I have a 10-year-old student with severe asthma. This child was seen at the urgent care 7 times since January, which amounts to about every 2 to 3 weeks, and oral steroids on each visit with a charge to see the child's primary care physician, but this has not been done. This child's missed approximately a quarter of the school year. What can I say or do that will help this parent to understand the problem with using steroids so frequently and not following up with their medical home physician?
Tell them their child is going to die.
Oh,
that always gets their attention.
That might be just a tad dramatic for this webinar.
Sorry. But I do use. I actually do say that sometimes. I do use something shocking. And you have to shock these people. They see their child suffer. They see that the child is not breathing. They understand that they got to get this kid some help, but then as soon as the kid's looking better, they forget all about that. They need to be shocked, and there's obviously different levels than that, but the emphasis needs to be on long-term adverse consequences of this. You can use the growth argument. Kids like that are never under good control. There is always a lot of inflammation in the lungs. They're on the high doses of oral steroids. They're not going to grow that well. But the problem is that if a parent is seeing their child gasping for air for 2 to 3 days every couple of weeks, that's probably not going to make much difference to them. So you just need to get we've talked about a lot of the adverse effects of the oral steroids, the frequent oral steroid use, some of the adverse effects of not having asthma under good control. And so you need to have the conversation with the parents, get an idea of where they're coming from, and figure out what kind of message is going to resonate the best with them to get the care that their child needs. And I apologize. I was probably
That's okay.
little severe for a school nurse. That's a little it's on the edge for in the allergist's office. But I do use that, and sometimes it works. And I have had people come back to me and thank me later. And they said that was a kick in the tush, and that's what they needed. So. So it's on the table, but you have to feel out what's going to resonate with the parent.
Well, and I've been in school nursing for almost 30 years. I hate to say that sometimes because of what that makes me sound how old I am. But another thing that might be very helpful to you in this situation is when you're working with parents, if you are frustrated and just can't seem to make headway, if your school has a medical director, that person can help act as a liaison, as well as if you have a school social worker. So think too about what other resources you have to help you with this family, because that can be very helpful as well. So we can take one last question. Somebody asks the question: where does the drug Xolair fall in these with all of this? I've been on these injections for 2 years. My asthma is more controlled than ever, but am I risking having long-term side effects?
There really aren't any identified long-term side effects of Xolair. That's one of the nice things about using Xolair amongst the biologics. It's the oldest. I was first involved in clinical trials with this drug in 1996. It got FDA approval and has been on the market since 2003. We do know that there is a risk of anaphylaxis after an injection that is much lower than standard allergen immunotherapy. And that's really it. And we haven't seen any additional long-term side effects that come with cumulative exposure. So right now, there isn't any significant concern. There have been various side effects. Don't get me wrong. All in very small percentages and in different clinical situations. But there has not been anything over 15 years of experience that has shown that there is any substantial cumulative adverse effect with Xolair use. And so if it's working well, you can go for it. Now, if you're talking about decades, some of the people that we first had on Xolair, well, actually, there aren't very many people that we first had on Xolair because we had an awful lot of trouble with insurance coverage in the 2005, 2010 area of it, and it was very difficult to keep people on Xolair. So we don't have a lot that have been on for 15 years, but I think that the biologic therapy is much more accepted these days. We're doing what it takes to make sure that people who benefit from these drugs can take them long term. And if you're talking about taking a biologic for 10, 20 years, it's getting to be the time in which the underlying disease itself may be changing, and you may not need that much medication anymore. And that is just a conversation to have with your asthma specialist to determine whether and how to determine if you still need to use the Xolair.
Well, thank you so much, Dr. Stephen, and I'd like to thank all of our participants for listening today. Please join us next month for our June webinar, where we will be presenting the Itchy and Scratchy Show, Handling Severe Atopic Dermatitis. This webinar will air on Tuesday, June 19th at 4 p.m. Eastern. You can register for the webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page on our website. Please visit our website for quality guidelines-based resources on allergy and asthma. If you could move one slide forward, please. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We hope you have a great and a healthy day as we work to breathe better together.